To the third article, we have Dr. Sushil Patel, who is organizing secretary for this monthly metabolic disease review meeting also. He is a consultant diabetologist from city Vadodara, and the article is from Diabetologia. The topic is predictors of hospital discharge and mortality in patients with diabetes and COVID-19. Updated results from national-wide Coronado studies. Over to Dr. Sushil Patel. Yeah.
Thank you, Yash. And again, I welcome you all on behalf of Organizing Committee of Metabolic Disease Review. So after two wonderful sessions on the diabetes articles, this is article related with the COVID and diabetes. That is a predictor of hospital discharge and the mortality in the patients with the diabetes and the COVID-19. And updated results from the nationwide Coronado study. So this article is published in February 2021 in the Diabetologia journal. This article is from the France. Why this article is important? Because the diabetes has been shown to be associated with the worst prognosis in the COVID-19. And indeed, the prevalence of the diabetes was 2 to 3-fold higher in the patients admitted in the ICU compared with those with the lesser severe disease, and even the mortality rate is also again associated with a higher rate in the patient with the diabetes. So Coronado is a French nationwide multicentric study, the first registered study that specifically aimed to describe the phenotype characteristics and to identify the prognostic factor in the patient with diabetes hospitalized for the COVID-19. So that is why it is important. The present analysis reports results from the complete Coronado study, totaling 2796 patients from the 68 centers with the complete follow-up of the 28 days. So in a short-term interim analysis, which is published ahead of this article, that is Coronado interim analysis study, in that article, they had taken 1,300 patients with the diabetes admitted for the COVID-19, and the poor outcome within the 7 days, where in their result that they are independently associated with the BMI or the age or the diabetic complication, treatment, obstructive sleep apnea, and the some biological factors. But afterwards, they had extended the study and they had taken more number of patients, and the outcome they had studied for the 28 days. And this is the update of the results from the previous report of this Coronado study. Patients were screened after the hospital administration from the 10 March to 10 March to 10 April 2020. This is the time where the India is at the very initial phase of the COVID-19, but in the European countries, the COVID-19 was at the peak. Parameters they had taken like the age, sex, and the BMI, patient history like the hypertension, microvascular complications, COPD, or the obstructive sleep apnea, routine medication, metformin, insulin, ARBs or ACE inhibitors or mineralocorticoid receptor antagonist, statins, anticoagulant therapies, symptoms on the admissions like the time duration between the symptom onset and the hospital admission, fever, and the dyspnea, biological factors like the eGFR or the AST level or the white cell count or the platelets or the CRP at the time of admission, again the blood sugar level and the HbA1c at the time of admission. So out of 2796 participants, mean age of the participants were 69.7 years. The men are around 63% of people are male. Median BMI is 28, median CRP is 86, median HbA1c was 7.9 in this study. Microvascular complications were present in 44% of the patient, and the macrovascular complications were present in 38%. Within 28 days of the study or this follow-up, that 50% of the patients were discharged from the hospital with a median duration of the hospital stay that is around 9 days. There are 11% patients also that had been discharged in 3 days also, while 577 participants, that is 20% participant died during this 28 days. So this is the study, again I'm reminding, this is in the initial part of the COVID outbreak. So factor that is associated with the discharge or factor that is associated with the less mortality. The first is the women gender. The second is the younger age of the patient. Routine metformin therapy or the patient, if it is on the routine DPP4 inhibitor therapy, then they have shown some beneficial effect in the discharge or the mortality point of view. The longer symptom duration before the admission, again it has favorable effect on the discharge or the mortality. And this I am just concluding in short. that factors that reduces the chances of discharge, high mortality rate, the older age of the patient. They divided the age group less than 55, 55 to 65, 65 to 75, and more than 75, and shown that the age is advanced, the mortality chances or the chances of discharge are worsening. The male gender has a higher risk. Hypertension, if the patient is already having, then they are at the higher risk of mortality or the reduced chances of discharge within the 28 days. If the patient has a history of micro or microvascular diabetes complication, if the patient is having the history of heart failure or the COPD, then they are at the high risk. If the patient is on the insulin, again they are at the high risk. Surprisingly, in this study, they had shown that if the patient is taking the statin, then the chances of mortality or the discharge, they are worsening. And the patient on the diuretic or the beta blocker, dyspnea on the admission or the fever at the time of admission, they had shown that the chances of mortality or the reduced chances of discharge. At the time of admission, higher AST level, higher white cell count, lower platelet count, and the higher CRP level, again, they had worsened the outcome of the patient. And again, with the regards to the HbA1c and the blood sugar value, in this study particularly, they had shown that whatever the HbA1c level, that doesn't matter, but at the time of admission, what is the blood sugar level, that matters for the worsening the outcome of the patient. So that may be the surprising, because they had compared with some other studies which is done in the USA and the European country, and they had shown that the HbA1c also does matter when the patient is suffering from the COVID, and the blood sugar value again does matter. So identification of the favorable variable associated with the hospital discharge and deleterious variables associated with the death can lead to the patient reclassification and helps to use the resources adequately according to the individual patient profile. And this is very important in the current scenario, which is prevalent in the India, where we have some shortage of the remdesivir or some shortage of any other drugs which we are using in the COVID treatment. So if we can generate our own data regarding the prognosis factor of the patient suffering from the COVID, regarding the discharge or regarding the mortality, then we can reclassify the patient criteria scenario, and we can use our resources in the right kind of patient. Again, the limitation of the study is that they had not included the therapy point of view of the COVID-19. So corticosteroid use or the immunotherapy or the antiviral agents could influence the prognosis, and this is not studied in this particular study. But definitely right now, majority of the patients are on this any kind of this therapy. So definitely the prognosis factor will change. So this is just a reference section of the Coronado study, which is initially published in 2020, and afterward this action is published in 2021. So again, thank you very much, and thank you to the whole team.
Thank you, Dr. Sushil Patel, for that nice presentation. So the first edition, like as Dr. Sushil Patel has pointed out, was a 7-day follow-up of the cohort, and now they have had time to follow them up for 28 days to study discharge and death. I think the most important finding for me, at least, was it answered one question for me. Well-controlled individuals with diabetes versus uncontrolled individuals with diabetes. That was a question which has been haunting me, right? Is the outcome different? And this paper did answer that, although it's not a thing that they've included in the abstract itself, but somewhere in the middle, they do say that pre-admission HbA1c did not correlate with outcomes, be it discharge or be it death. So that's an important finding.
Madam, they had again,
but pre-admission,
they had again said in the discussion part that in other studies, HbA1c does matter. So we have to find out in more detail about the current scenario, which is available or prevalent in India.
True. But the more important glycemic variable which managed to predict outcome happened to be the pre-admission GRPS. So that is again something that we should all regularly and routinely ask for. In the chaos that is happening right now, we are getting patients admitted without even a pre-admission GRPS being done. So at admission, just making sure that the team at triage does get GRBS done is important. Second, before we generalize this high mortality rate is 20%, right? It's important to remember that they only included people who had moderate or severe disease who were hospitalized, right? They did not include mild individuals at all. That's an important thing. We can't generalize this to all individuals with diabetes, although it did include individuals who are diabetes. So this is a 20% mortality rate in moderate to severe illness of COVID. Another big confounder, I think, Dr. Sushil, is the fact that up to 76% of people had hypertension. And between diabetes and hypertension is known to contribute greater to worse outcomes than diabetes itself, as we've learned from other studies which have looked at outcomes from COVID patients. So those are my
They had
takeaways.
mentioned also that the hypertension will increase the chances of mortality or reduce the chances of discharge in this study.
True.
So on your sharing, there is wonderful clinical aspects just touched upon. In last these almost 15 to 16 months, or I'll say specifically 12 months, what we have seen is chronic follow-up patients, and we really miss out is their pre-infection glycemic control, and that's where how we can connect to them in between time and prevent both good euglycemia at the better stage and the prevention of COVID. That could be the two communication we can forward further. Thank you for those inputs. Yes. Any of others delegates, if they want to share something about it?